Thank you, Dr. Gua, for the kind invitation. So yes, the all the talks what were delivered prior to my presentation were all focusing on the choroid and the retina. So the course description told me to speak something about biopsies, particularly related to choroid and retina. But I will touch something related to sub-RP because that is also very important space which is between the retina and the choroid. And being in ocular oncology, there are a lot of tumors which are kind of originating, or we assume that that is arising from that particular space. So I will be talking about something related to sub-RP biopsy also. So before I start, we all know I think biopsy is very, very important, particularly from the ocular oncology point of view. We can do biopsy particularly from the point of being to diagnose particular condition, wherever clinical acumen or the multimodal imaging might not help us to reach to a final conclusion. In some cases of tumors, even though the diagnostic is confirmation, but we need prognostication in terms of future surveillance in terms of risk of metastasis. And very rarely we do take biopsy, which itself can be a therapeutic option for the particular case or the particular tumor. Biopsies, if you broadly classified, they can be classified either the incisional biopsy or excisional biopsy. From the scope of this presentation, I'll be limiting myself only to incisional biopsies and particularly limited to sub-RP and full thickness retinochoroidal biopsies, which can be achieved using an intravitreal approach. Before we jump into the cases and the procedure itself, I think it is very important that you know what instruments we need to have. We need to make sure that all the techniques and all the procedures related to biopsies are all in place before we jump into doing any kind of biopsy. Because once you take the tissue or the specimen, it is gold standard, and we don't want to miss not being able to take that specimen or the tissue to reach to the pathologist. So make sure that you have everything in place before we go on to obtain any kind of biopsy from the eye. For the posterior segment, usually the fine needle aspiration biopsy involves whether the tumor is located pre-equatorial or post-equatorial, and depending upon the location of the tumor, you can obtain a biopsy either through a transscleral approach or a transvitreal approach. From the intravitreal, because we all are retina surgeons, we are kind of very kind of confident in doing the retina surgeries. So I think being a retina specialist, it is easy for us to obtain any kind of biopsy from the posterior segment, particularly whether it is a tumor or any mass or any suspicious lesion. So we do a standard 3-port sparse plane vitrectomy. Important point is make sure that you're using a valve trocars, because always the risk of tumor seeding is always there in case of any intraocular tumor. So you don't want to miss that aspect of the tumor where you're doing a biopsy and inadvertently you're causing a tumor seeding, where you are making the case from an intraocular to an extraocular extension. So make sure that you are using ports with a valve trocars, and at the end of the surgery, make sure you're doing cryo or you're suturing your ports if you feel the scleroderm ports are leaking. So I will describe few cases. This is a case of 52-year-old female. She came with an prior diagnosis of choroidal granuloma, presumed to be tuberculoma. She already received 1 year of ATT elsewhere, and despite an oral steroids and couple of anti-VEGF bevacizumab injections, and despite all this going all across 3-4 institutes in India, ultimately she landed at our place, and this is the imaging what she already was carrying. We did only ultrasound to just demonstrate what we are looking at. So what you can see in this clinical fundus photograph is a melanotic choroidal lesion, because you can see it is elevating from the choroid. Overlaying retina, you can see there is a bump. The retinal vessels looks normal, and there is a surrounding SRF which is leaking into the macular area. ICG, you could see the lesion remains hypofluorescence through all the phases of angiography. OCT shows a smooth dome shape elevated choroidal lesion with compression of overlying choriocapillaries, kind of photoreceptor disruption, and some amount of SRF. B scan is very, very important. What you are seeing is high surface reflectivity, and the reflectivity keeps on going down, as you can see in the corresponding A scan spike. And this is very, very classical description for choroidal melanoma, also known as angle kappa. So I think the therapeutic trial of ATT, which was done for presumed tubercular granuloma, didn't work. Anti-VEGF injection, even people give intravitreal moxifloxacin for tuberculoma, that also didn't work. And the imaging what we did at our place, it shows that this we are dealing with a mostly an amelanotic variant of choroidal melanoma. Patient was very apprehensive. We were sure that we are dealing with an intraocular mass lesion, but the patient wanted a diagnostic biopsy before we jump on to label any patient to have an intraocular tumor, which can have its consequences throughout the life. So we went ahead and did transvitreal fine needle aspiration biopsy. So what we use is a long 24 gauge needle through one of the 23 gauge trocars, and we directly go to the most prominent portion of the tumor, avoiding any major retinal blood vessels. And with a back and forth movement, what I am trying to do, the sister is slowly aspirating the material what we are collecting from the tumor substance, and this we fixed in 70% absolute alcohol and send it to pathologist as early as possible, if not on the same day. And you can see at the end of the procedure what we want to make sure that there will be some amount of bleed or some amount of blood clot on the area where that your incision was made. Make sure you increase the infusion pressure to 60 millimeters of mercury, come out and stay in that current position for 1 or 2 minutes till you look at all your biopsy material, and go back inside and see that usually the blood clot might have already kind of clotted, and there's no need to do any laser or any tampon or anything, because the underlying choroidal mass itself will serve as a buckle kind of element. It will close the biopsy site. So this again proved both the immunohistochemistry markers, melanin and HMB45, which are very strongly expressed in particular in case of melanoma, came positive, and this patient underwent required plaque brachytherapy, follow-up for last 3.5 years, no systemic metastasis, and everything going well. So this is the role of biopsy, particularly from the diagnostic point of view. From the prognostic point of view, yes, in India we don't have any very good markers from the prognostic point of view, but in Western countries they do usually prognostic biopsies, particularly for all choroidal melanomas, to look for any future systemic metastasis, risk of metastasis, and how soon they should be doing underlying systemic screening to look for any metastasis. The second topic which was given to me was sub-RP retinochoroidal biopsy. So I think this is usually done in cases which are atypical presentation, patients particularly chronic uveitis which are not responding to your first line of treatment, steroids, immunosuppressants. There is a diagnostic dilemma, and very rarely, being ocular oncologist, I do see sometimes patients referred for a suspected or undiagnosed primary vitreoretinal lymphoma. The yield what we get from this space is very critical, because this is the area from where the tumor cell infiltration is the maximum. So if you just do a vitreous biopsy, the yield will be only 30 to 40%. So that's very critical where you want to obtain the biopsy, from which area you want to obtain the biopsy. So I will just jump into a few cases. This is if somebody shows this case from the retina point of view, ocular oncology point of view, you know what is the diagnosis. You see multifocal discrete yellowish subretinal lesions with overlying vitritis. Patients already have been diagnosed to have uveitis, received corticosteroids, tapering. Again, the lesion flares up. So waxing and waning course of steroid gives a positive clue that you are dealing with an underlying primary vitreoretinal lymphoma. But yes, being an ocular oncologist, for me, always biopsy is gold standard, because it is not just about the eye, it is about the patient. So always the patient wants a confirmation that yes, they have an underlying malignancy, particularly lymphoma. And you do an OCT. OCT is also a very important tool, which again demonstrates where these lesions are particularly located. That's what you see in this OCT, sub-RP infiltration of the lymphoma. So what I do is a very simple novel technique. What I do, I use the soft tip cannula, I cut it and make it a little bit of bevel, and then I kind of attach this soft tip cannula to a 2 ml syringe, and sorry, the vitreous biopsy, as we do for any other case, I take undiluted vitreous biopsy followed by diluted vitreous biopsy, or the cassette fluid you can send. And last but not the least, because you can see all these lesions are in the sub-RP space, what we use is this novel subretinal aspiration cannula, which is cut and made bevel. And if you have an intraoperative OCT, that helps you to guide where you're putting your cannula. So what you will see now is I'm using this bevel cut soft tip aspiration cannula, and I'm directly going into the sub-RP space where there's a maximum infiltration of lymphoma cells. And this helps to increase our yield from 30% in case of vitreous biopsy to as close to 70 to 80%. And this I am doing for last 2 years, and this has increased our positivity rate for vitreoretinal lymphoma. So this can be without intraoperative OCT. If you have it, is good. Otherwise, as being a retina surgeon, I think we are very confident we can easily do this. So it's nothing something novel. But yes, important thing is once you obtain the biopsy, you have to make sure this has to be sent freshly to the pathologist. You have to be communicate with your pathologist and make sure that 30 minutes it reaches to the pathology. They have to look for in the cytology to look for active lymphoma, B lymphoma cells. So again, you could see in this pathology specimen, it came out to be diffuse large B cell lymphoma. Patient underwent 3 cycles of biweekly methotrexate and it responded beautifully to the treatment. Last, I am just going to show one case about VKH. This was from the UVIT clinic. Patient was already diagnosed with VKH. Multiple vitreous biopsies were done. However, every time it showed inflammatory precipitates or inflammatory debris and no atypical cells were seen. OCT again showed some kind of infiltration in the sub-RP space. So in this case, I couldn't do vitreous biopsy because already multiple vitreous biopsy attempts were done. So I'm sure that I'm not going to get anything from the vitreous specimen. So I directly went and did full thickness retinal corridor biopsy. So this is the video which just shows how we do retinal corridor biopsy. So important point again from the ophthalmologist point of view, make sure you choose an area. It is kind of very close to the posterior segment because you are not going to use any tampon or anything. If you do in the periphery, there is a high chance patient might develop regmatous retinal detachment. Second point important, make sure you always choose an adjacent normal area of the retina when you are taking retinal corridor biopsy, because the pathologist always wants to compare it with the normal adjacent retina. So you do your normal diathermy as Dr. Mittal was showing. Same thing, you do diathermy all around your area of interest, and then you use scissors to take small amount of retinal tissue. I'll just skip. Yeah, small amount of retinal tissue from the area of interest, and then what you again use a MVR blade, slice onto your underlying choroid, do cautery, and take small amount of choroidal tissue also. So here I'm not only just kind of limiting myself to retinal biopsy, but retinal as well as the choroidal biopsy. So you can see I'm just taking a small amount of choroid also, and this case again proved out to be primary vitreoretinal lymphoma. So you can see that in cases even your multiple vitreous attempts or biopsy have come negative, if your clinical suspicion is very high and patient is not responding to your treatment, I think you need to kind of devise an approach which is appropriate for that patient, and ultimately you do laser all around and you close the case under air. So last, I will just say, yes, there are some complications related to biopsy. We all need to be sure that this is the only attempt what you have got to take the biopsy. So make sure that all your instruments, all your pathologists are informed well in advance. And complications related to biopsy, yes, sometimes you do across see vitreous hemorrhage, retinal detachment, but yes, they can be easily managed as we do for any other retinal related complications. So I will conclude. In ocular oncology, biopsy still remains the gold standard. Appropriate surgical technique with careful tissue handling is very important, and negative biopsy does rule out any possibility of intraocular tumors, and a multidisciplinary approach is the need of the. Thank you.
Thank you, Vishal. Stay on. We'll take some questions. Fantastic presentation. And in fact, I have learnt a lot myself.
Thank you.
So, one or two things I want to ask you. During FNABC procedure, you are using a 24 gauge needle, you said,
Yes.
and the sister is exerting suction, aspirating suction. So, of course, it's a manual suction.
Yes.
It cannot be automated. So, would you also have any modality of automated?
So we can use our vitreous infusion suction, what we have whisk, what we get. But again, it depends on what syringe you are using. So in that we use a 5 ml syringe. And these tumors or the specimen is so less, we can't aspirate that much. So what I do, ideally I would have loved to have a long 26 gauge needle. That's what I'm going to explore today in the trade area, if I can get a long 26 gauge needle, because
you can try that in the Pricon store.
I'm going to try that.
Yeah.
So because I have to we put one 23 gauge trocar and put a long 24 gauge needle through that. So the amount of specimen what we get, because the needle has a bevel edge, people use cutters also, 25 gauge or 27 gauge cutter to take the biopsies, but the bevel edge of the needle helps both the pointed edge to slice the specimen and cut it, and the sister usually what we see is just keeps on aspirating till it reaches the 2 ml. So you might not see any fluid or anything, but everything in the bore of the needle, you will see some kind of brownish deposits of material get collected, and that you have to flush with either with normal.
She is aspirating till the material comes to the hub of
hub. You will not see anything in the syringe.
Fantastic.
It will be always empty.
So the next one is that you said it's a 41 gauge, the soft tip cannula. You were
no. It's a normal soft tip aspiration cannula what we use for a PVD induction, everything. Same thing.
And the principle is the same. You are inserting that cannula under that
under the our retina. So because if it is normal aspiration cannula, it will not go penetrate retina.
Huh.
So I just cut it, make it a little bit bevel, so it has a little bit pointed edge, and then it easily goes into a sub-RP space. So
There also, I think, Pricon, you will have some gadgets in which it's easier to insert it through the retina. They have a steel tip.
no, we don't need a steel tip.
okay.
We need something malleable. So this, I think
I
this
was just
works.
worried about the penetration part of it.
No, no, it easily penetrates. Should not be a problem.
Because as it maybe those retina is friable already.
Yes,
over
already
the
3D
tumor.
matters, so it easily penetrates.
So, and I was also charmed by the way he described the methodology and also the site that you choose for the biopsy. You choose the normal and the pathological border of the
Adjacent,
lesion.
yes.
That's wonderful. And any other questions from the audience? Yeah, please.
So you have taken the tissue, the sample you have taken. What is the care you need to take before sending to a
Louder.
pathologist?
So make sure you communicate with your pathologist prior that you are taking a biopsy for a particular case. Ideally, the pathologist should be in your operation theater. As soon as you take it, within 30 minutes, it should be sent for cytology or cell block, depending on what you are taking. If it is a vitreous biopsy or any aspirate, usually they prepare cell block. If it is a tissue specimen like retina or the choroid, you can fix in formalin and they can do histopathological section.
If the pathologist is not in the vicinity,
Yes, so if it is not available, particularly for lymphomas, if the pathologist is not available, you are taking a biopsy in the evening when you know that you need a transport medium. So Western countries they have cytolite, but in India, unfortunately, we don't have. Then you can fix in 70% absolute alcohol. Don't use formalin because that lyses all the cells. So 70% absolute alcohol is something what you can use for transport medium.
And also the steps that you are accessing the choroid in the retinochoroidal biopsy. Too much use of diathermy will destroy the cell. So
Yes.
you have to have balance.
Yes, so you don't want bleeding also to happen and you want adequate
Balance.
tissue specimen.
So last,
yes.
while dealing with Dr. Sangeet's videos,
Yes.
I was referring to you. So any tips for avoiding air embolism? One of them, I've heard somebody ligating the vortex veins, something.
Not ligating the vortex veins. So what Dr. Mittal had shown is a beautiful video of retinal angioma where he went and did endo resection kind of thing and kind of eat it away. Either you can endo resection or you can do end block resection and keep it out. Main thing is the bleeding because these are all not kind of normal retinal vessels.
To avoid
They are-
air embolism.
So air
what are the-
embolism, you can use PFCL, but again PFCL is also dangerous. The people have shown reports where
Yes.
even PFCL itself is a gas. So this
Absolutely.
gas itself can go through your vortex veins or scleral perforator veins and cause air embolism. So you have to make sure you have to tell your anesthetist to be standby whenever you're doing any kind of large endo resection. Because I do choroidal melanoma endo resections, I make sure I keep the anesthetist informed that this is I'm going to do. The BP should be as low as possible. So you can't do all these surgeries, intraocular surgeries, particularly where you're doing retina or the choroid excision and your blood pressure shooting up. So make sure you keep your anesthetist well informed what you're going to do and you observe these patients. If required overnight, you can admit them and see them next day.
Thank you so much, Vishal.
Thank you.